well. I just need to proceed now with the lower limbs. Now in the lower limbs, guys, we need to connect, and we have a joint. We have the hip joint, and the hip joint is made between the head of femur and the acetabulum. And you guys know that you have your acetabulum in your hip bone. All right, so the acetabulum has acetabulum in Latin means a cup-like structure. So the acetabulum, which is your cup-like structure, it has two parts. It has a very deep part, which is filled with fat and stuff that is not related to my hip joint. And the outside, the lunate articular surface is basically, if this is the acetabulum, I have the lunate. Lunate means a crescent shaped, okay, crescent shaped. Okay, this is the articular part of my acetabulum. So the head of femur is going to articulate with the outside lunate articular part of it. Why is it lunate? Because you guys, if you look at the acetabulum, you will find that the acetabulum, you guys, has an opening here, all right, because it's not a full cup, it has an opening. And that opening, we call it acetabular notch. All right, so we call this an acetabular notch. It's an opening. But will we leave it like that? Definitely not. We need to close it off. How will we close it off? We have a ligament, and the ligament that comes transversely to close an opening, we always call it what? Transverse acetabular ligament. Remember, you guys, that transverse scapular ligament that sealed off the suprascapular notch and or fossa and made it a foramen for the suprascapular nerve. The same thing we have here. We have the transverse acetabular ligament, and that is going to close off the acetabular notch. But why in the first place we had it open and we are sealing off with a thin ligament? Because you guys, you have a very important ligament that is trying to pass through this area to reach the head. And that ligament is called the round ligament of the head of femur. And that is going to come from the open space. It blends together with the ligaments around them. All right, but that is because we want the round ligament to go ahead all the way and attach itself to the fovea, because the head of femur, it has a depression called fovea, and that is to accommodate the round ligament of head of femur. Why is that? Because we need to attach the head here, because we need to support, and also because we need to send blood supply of that ligament and to a part of the head from the obturator. You guys remember, this is the obturator membrane, and it has a canal. Okay, the canal is for the obturator artery, and from the obturator artery I'm going to send a branch, and that is a branch to the round ligament of the head of femur. It's going to go to supply that area, and it's going to kind of give a little of blood supply to the head. So that is all to accommodate for the branch that needs to reach the round ligament. So we call it the branch to the round ligament of head of femur. All right, so that's a whole story to accommodate for this blood supply. And we're going to talk about the rest of the blood supply when we talk about the femur. Now let's talk about the rest of the ligaments. What kind of ligaments would we have? Definitely, if I have a hip bone which is composed of pubis, ischium, ilium, I'm going to have a ligament from the ilium, from the pubis, from the ischium. And now what do you want to call them? It's very simple and easy. If I have a ligament coming from the ilium, and that is basically a Y-shaped ligament, this is basically a Y, and this is the strongest ligament, and it prevents the hyperextension of the hip joint because it comes from the ilium. Ilium is anteriorly, all right? So I'm going to resist the opposite function. If I'm anterior, I'm going to prevent hyperextension, okay? Try it on yourself now. Try to do hip extension and see which ligament is going to be taut. It's definitely your iliofemoral ligament. If you put your hand right now on your hip joint anteriorly on this region, you will feel that this is the part that is going to become stretched when you are trying to hyperextend your hip, all right, or your thigh. All right, so This is the iliofemoral ligament. Now, what about the other ligaments? I have another ligament coming from the pubic bone for the femur, and that is going to be my pupofemoral ligament. All right, so I have a pupofemoral, and if I have a ligament coming from the ischial bone and going all the way to the femur, I'm gonna call it the ischiofemoral ligament. But the ischiofemoral, you guys, is the weakest ligament. All right, it does not do other than support, but the iliofemoral is very important. It's the strongest. It prevents hyperextension. Pupofemoral is important because it prevents hyperabduction or over abduction, so this is also good. However, the ischiofemoral is not of great importance and support. All right. And definitely in any joint, you guys by now know that in any joint, if I have a meeting point between two bones, God created in a very nice way, which is basically you have a synovial membrane that lines your articulating hyaline cartilage of your bone, because your bone, guys, if you have a joint, you need to have a cartilage, hyaline cartilage, to face that synovial joint. It's not going to be a bone. And from there, you have a lining of synovial membrane that has the ability to give you synovial fluid for lubrication. And after that, you need to cover those guys with fibrous connective tissue from outside. And that fibrous connective tissue needs to condensate laterally and form the ligaments that is going to further support and attach the adjoining bones together. All right, so these are a basic information. Let me do the fibrous connective tissue in a different color. This is basic information you need to know. And another thing you need to know is once you are ready with your joint and you are going to receive a muscle tendon, you need to have bursa, all right, because these bursa are going to release the tension and, you know, reduce the friction, and it gives you the ability to move your tendon above those fibrous structures up and down. All right, so this is the basic thing that you guys need to understand for any joint you have in the body. All right. And these are just more pictures that to show you the ligaments. If you are here between the ilium and femur, this is the Y-shaped iliofemoral ligament. If you have a ligament that comes from the pubic to the femur, we call it the pupofemoral ligament. And if you have a ligament from the ischium to the femur, we call it the ischiofemoral ligament. All right, guys. Now, like we said, we have structures that pass from the greater sciatic foramen and they come back to the lesser sciatic foramen. And I have a mnemonic for that, which is S spin pin. I'm not gonna say them now. I want to say them at the end because they will make more sense when you understand these structures first and you know from where they are coming, what do they supply and what do they do, how do they look like, and then it's very easy to then memorize this mnemonic and relate it to the openings. So we're gonna come back to this when we are done with the rest of the topics. So this is just an extra picture to show you guys how the round ligament get attached to the head. And I already talked about the idea of the hip joint, and we understand now the transverse acetabular ligament and everything in this. And this is in a real cadaver. This is the round ligament, and this is the lunate articular surface, and this is the non-articular surface here deep down there, and this is the head, and this is the femur. And this is, of course, the obturator membrane. And from here, from the foramen, you will have your artery escaping from the obturator artery to give you the branch to the round ligament and to a part of the head. Now, what about the femur? If you guys look at the femur has a superior part and inferior part. The superior part, it has the head, neck, shaft, all right? So if you look at the head of, all right, so everyone knows the head, and you have a depression here, we call it the fovea, and that fovea is what accommodates your round ligament. And then if you look at the elevation, remember the greater tuberosity and lesser tuberosity of your humerus. Here we have the greater trochanter, lesser trochanter, because trochanter in Latin means something that is further bigger than the tuberosity, all right? And of course, this is your femur, so the elevations are going to be exaggerated in here. So you have the greater and lesser. If you are looking from the back, all right, if you're looking from the back, the line between them is going to be the intertrochanteric crests. If you are from the front, the line between them is going to be called the intertrochanteric line. The line is going to receive ligaments, but the crest is going to receive muscles. And the most important muscle that goes here is the quadratus femoris, guys. And it makes sense also because the quadratus, it has a quadrate like shape. It's a square shape. So definitely one of its borders, it's going to be quadrate, so it's going to accommodate the whole thing, and you will have also an elevation, we call it the quadrate tubercle. All right, so if you look at this elevation, it's the quadrate tubercle, and that is here going to be for attachment of quadratus femoris. That's why it's elevated. And the line is going to be for attachment of ligament. And because the muscle is going to take the part here, the intertrochanteric crest, the ligament, guys, when they come and they want to attach themselves, they are not going to go to the crest. They are going to stop earlier than the crest, and then they will kind of wrap around here to form the orbicular fibers running around the neck of femur. However, the ligaments, when they want to come from the front, they can go ahead all the way to the intertrochanteric line. It's fine and easy. However, when they want to come from the back, they cannot reach the crest. The crest is already occupied with the muscle. They will stop earlier, and the people who are going to stop earlier and wrap around, we call them the orbicular fibers. All right, the orbicular because it's an orbit. It's gonna be circular fashion. All right. Coming back, so we have the greater trochanter, lesser trochanter, intertrochanteric crest. We have the neck, we have the head, and then we have elevations. The lateral, very big elevation, and let me just help you. So someone will tell me, I don't know which is the anterior and which is the posterior. Fine. Anteriorly, guys, you're gonna have this part that accommodates your patella. So you will have the patellar surface of the femur. So this is anteriorly, and posteriorly you have the condyles, because this is going to articulate with your tibia and make your knee joint. So this is posterior and this is anterior. So these are the femoral condyles, and we're gonna talk about more details about the lower parts in the knee joint. Now, what concerns me here is up. Now, since I know that the crest is posteriorly and the condyles are posteriorly, I mean this is posterior. So what do we have posteriorly? Posteriorly, we have laterally a tuberosity. We call it gluteal tuberosity. This is going to be for insertion of gluteus maximus muscle. I have an elevation medially, which is what we call the pectineal line. All right, the pectineal line here medially. And then if you trace those guys, you will find the medial and lateral lips of the linea aspera. We have here a linea aspera. The linea aspera, if you trace it up, you will find a lateral lip and medial lip. And we're going to talk about those guys later on. So, gluteal tuberosity, pectineal line. Lateral lip, medial lid of linea aspera. Once you're done with linea aspera, you will split yourself back into the supracondylar lines or ridges or those elevations. And we're going to talk about more of this as we reach the region. So you need to know that you have the linea aspera. If you trace it up laterally, you reach the gluteal tuberosity. If you trace it up medially, you reach the pectineal line for pectineus muscle. And we're going to talk about it in the adductors and flexor groups. And if you trace the linea aspera down, you will split yourself into lines that are above condyle. We call it supracondylar lines. All right, guys, and these are the things that we need to know. And here we have good pictures for the medial and lateral condyles. You will have the popliteal fossa and you will have the patellar surface. We're going to talk about this as we reach those regions. in the lower part. Now we have a very important angle that we call it angle of inclination. This is basically between the long axis, let me draw on the normal one, the long axis of the head with the long axis of your shaft. If you try to measure the angle, this angle, you guys, should be around 120 to 135 normal. If your angle is less than that, if it's less than that, we call it coxa vara. If it's more than that, we call it coxa vulga. Coxa, it's related to the hip joint. Vara, because it means this is less. Vulgum, it means it's more. So how can you remember that? It's the opposite. More has an R, it goes to the vulgum L. But less L goes to the vara R. Okay, so less goes to vara, more goes to vulgum. It's the opposite. And all right, so in that case, you will have coxa vara and coxa vulga, and we will have the same idea in the knee joint, but in the knee we call it geno vulgum and geno varum. And we're going to talk about that as we reach the knee joint. Now, regarding the blood supply, like we said previously, we have the common iliac that comes at the level of L4, and then it gives you the external iliac that goes outside, and once it exceeds the inguinal ligament, it's gonna give you what's that? Yeah, this is external iliac, but for the others, yeah, once it exceeds the inguinal ligament, it gives you the femoral. Like if you have here the aorta itself, you have common iliac right and left. Common iliac, it gives you external and internal to the pelvis, if this is my pelvis. And once we exceed the inguinal ligament, we call it femoral. So it was common iliac, it became external iliac, and once we exceed the inguinal, we call it femoral artery. Now, once we reach the femoral artery, guys, it runs on the femur, it runs down, it's gonna give you a deep branch, and that deep branch is basically what we call the profunda femoris, or deep femoral artery. It's going to be deep because it needs to take care of people in the posterior aspect, and then it runs down. And I'm going to talk about the femoral artery later on when we talk about the adductors, because it has a very important course. But that's not going to be today. It's going to be now. It's going to be for the next videos. I just want you just to focus with me on the branches of the profunda femoral, because they will give you medial and lateral circumflex femoral arteries that will give you the retinacular blood vessels that needs to go ahead and supply the hip joint. And also you will have collateral, you will have a support coming from inferior gluteal artery and from superior gluteal. Of course, you guys know that these branches are coming from the internal iliac. And now let's get back to the femoral. From the deep femoral, you have the medial and lateral circumflex femoral. And then also you will have support from profunda femoris. It will send you an ascending branch. So definitely you have collaterals here, but I want you to focus on the medial and lateral circumflex femoral arteries. They are very important because they will give you the blood vessels that's going to supply the hip joint. Let's proceed and look at that. I want you guys to know that the medial femoral, the medial circumflex femoral, is very important. It will be able to give most of the blood supply to the head of femur. It runs anteriorly, and the lateral is going to be posteriorly. And how will you remember that? I want you just to remember that during development, guys, if this is your lower limbs and this is your upper limbs, what happened is during development, your upper limbs, they rotated or externally rotated. And that's why you have your hands like this. This is the anatomical correct position. It rotated outside. However, the lower limbs, they rotated medially. That's why you have your toes facing here. Why am I saying that? Because I want you to relate that in the humerus, we had anterior and posterior circumflex humeral. Here we have medial and lateral. So the medial is going to be anterior. Try now to put your finger in the front of your humerus and imagine that you are moving medially, what's going to happen? The anterior circumflex humeral artery that was anteriorly, when you rotate medially, is going to become a medial branch. This way you will remember that medial circumflex femoral artery is as anterior branch to the hip. All right. Why is that important? Because I want you to know this is the, if you look at the in the front of your hip joint, you will find that the medial circumflex femoral artery is anterior and the lateral is posterior. It's not memorization. It's something that makes sense, that during development, my lower limbs, they moved medially. That's why the anterior branch is called medial circumflex femoral. And this is the blood supply that gives most of the blood supply to your head. So if you have a femoral fracture, if you have a neck fracture here, what is going to be affected is your medial circumflex femoral artery. All right, so this is a very important exam question. Someone will think that, all right, we have a branch that is coming from the obturator artery to the round ligament, and that is going to supply part of the head of femur. Yes, this is fine, but that amount of blood supply is not going to be able to compensate for the loss that happened when we lose the very important medial circumflex femoral artery. So in that case, you can have an avascular necrosis, all right, to the head. You will have, especially for the distal fragment, because the distal or the affected fragment is going to be mostly affected. So remember, guys, when you have a neck fracture in the femur, the blood supply that is going to be injured is your medial circumflex femoral artery. It gives most of the blood supply, and that can end up having avascular necrosis. And yes, you have another blood supply coming from the lateral, but this is not going to be enough. You have some portion here toward the ligament coming from the obturator, from the artery of the obturator branch of the obturator artery, or they call it artery to the ligamentum teres, or artery of the round ligament of head of femur. This is going to be from the obturator, but this is not going to be enough.